Good morning, everybody. I think we'll start a couple of minutes early as there's lots to do. So welcome to this board meeting. And before we start the formal board meeting, we're going to have some feedback from the most recent 15 Steps Challenge, which a number of the execs and non-execs have just been to various parts of the hospital to have a look and see how it's getting on. So I'd like to start with who shall I pick out? I'll start with Pat and Kevin, who've been to haematology.
Yes, Kevin and I went to the haematology day unit, which is a small unit down at the front of the hospital. We started by going outside because some patients coming in might not know where this was. It's a specialist area and might be coming in for the first time. And we were pleased to see that it was well signposted. Go down the corridor, which is nice and bright, and into the unit, which is, again, bright. It's got natural light, which is important if you're going to be sitting there receiving drug treatment for some hours. It was very organised, orderly, clean, tidy and friendly. The staff, very stable staff. The patients, a very stable set of patients who come in on a very regular basis and are well known. There were a couple of patients by the time we left, and we talked to one of them, which Kevin will perhaps cover in a moment. But it was, it felt very calm, very, not cosy is the wrong word, but welcoming and friendly, which I think is very important for patients who are receiving that sort of treatment. The only issues that came up talking to the staff were that one of the staff, the senior staff, is now cross-site, and they were feeling the lack or the loss of that particular additional member of staff. And the more serious one was that there are sometimes issues about drugs which arrive from St Helier, having come from Bath for the treatment, and they sometimes miss the first transport, which is a courier. They used to come by shuttle bus, but that's been stopped for good reasons. It now comes by car, and occasionally it doesn't arrive in time for the patient, so the patient has to wait for the second delivery. So that was the only sort of issue that the staff were concerned about. The patients were, well, the patient and his two members of family who were there were universally appreciative of the care and attention that they received, and were very happy with the service.
Yeah, just to add a little anecdote there, I suppose, is that elderly gentleman that we spoke to, he'd been coming for his treatments for a few years. His children were born here 60 years ago, was the first child, and so he gave us an anecdote about his experience of not being able to see the baby till 7:30 at night, and only on Sundays or the day of the birth. So there was a few stories and improvements that they'd seen over the years. He'd also had his cataracts done here. He's had a double knee replacement here on the same day. So two knees on the same day. So he was very complimentary about Swelliok and Mr. Twyman, who did that surgery for him. And so, there was quite a few anecdotes that we could have listened to for a long time, but we had to come back here. So that was very good, wasn't it? They couldn't fault anything.
Thanks very much. Let's move down to, I think, Dan, you went to Gloucester Ward?
I went for Gloucester Ward, yes. Sorry, I don't normally need a microphone. So, having had a wander around, turned up, it was in the middle of breakfast time. The staff were being incredibly helpful. The patients were complimentary about them. I had a long chat with the team who were running the ward. They highlighted the fact they've got a very mixed cohort of patients. Normally it's supposed to be coronary and respiratory. They talked about having quite a high number of cancer care patients, but they were also quite complimentary about the support they were getting from elsewhere in the hospital to deal with a cohort that they weren't necessarily set up to deal with. I'd echo the points made previously about the ward look clean, calm. They're incredibly respectful and kind to the patients who approached them looking for help and went away entirely happy that they'd been given the answer they were hoping for. A couple of issues that came up in terms of flow and activity. where they talked about a lack of social services input onto their multidisciplinary meetings every morning, which I'll pick up as an issue afterwards. And they also cited the fact that they had therapists cover both physiotherapy and occupational therapy on the ward, dedicated, but due to some issues across the trust, those therapists kept getting pulled away and retasked elsewhere across the wards. So I asked them whether that had had an impact on the patients they had and whether they were creating movement, and their view was that this week it hadn't had an impact, but it could have done at other times. And they highlighted 2 patients who may have been ready to go that were so complex by the time everything's in place, they weren't going to go home till Monday, largely out of area patients. So they were happy that whilst they didn't get the full input they wanted, they were getting the service they needed, which is subtly different. So I didn't pick up any major dramas, but there's a couple of bits for me to follow up on afterwards.
Thank you, Dan. Let's move on to, I think it's Arun and Richard. Can you go to the Sunshine? You want to tell everyone what that is?
So the Sunshine Clinic is a new clinic. That is a paediatric clinic. It's just been opened up. It's actually a separate building from the main building. So I think the first thing is perhaps slightly difficult for people to know where it is, but it is signposted. So I'm sure people will get used to it in time. Brand new spanking unit, lots of consulting rooms, lots of lovely. The waiting room is lovely. They're talking about possibly building kind of like a garden area around it. I mean, it is beautiful. It's brand new. It is beautiful. The staff seem really happy. The boards were up to date. I mean, you couldn't ask for better. I think if I did have a criticism, it is probably, as we talked, overspec, underutilized. Can we use it more? There's, for instance, a meeting room there. It's a fabulous meeting room. Can we use it more? Is there, more cross-functional purpose in that building? But it is beautiful. I can't criticize. Nothing to criticize.
Richard, do you want to add anything?
No, I think I just echo. I mean, the 2 phrases I came out with at the end were, overspec'd and underutilized, and I guess also undersold to some extent. It just doesn't sort of necessarily receive the promotion or the priority. I don't know, but there are stacks more consulting rooms that are available than we have consultants that are able to utilise them.
So please bear in mind, it is the Easter holidays, so lots of people are on holiday. I've shown people around twice in the last 2 weeks, the new paediatric and maternity outpatient areas, and both times I've randomly gone up to staff and said, so is this better than where you were working before? And the answer is absolutely, because I now work in a space that has windows. There's a space where the patients can wait that is appropriate, and in the paediatric consulting rooms, we've actually got the space to have toys so that the kid can be a bit distracted while the examination is happening and while dialogue needs to happen between doctor and
It's an absolutely fantastic facility.
So, and if you think that only a few months ago, those were essentially inpatient mental health rooms, and how we have turned an environment that was pretty, for one group of patients, and they're quite a difficult group of patients, into something which now looks really amazing for outpatients. I think it's a big triumph to the estates team, actually. They pulled that off. So.
Thank you. Let's move on then to Elizabeth, the urgent treatment centre.
Yes, I went to the urgent treatment centre with Lisa and with Daniel as well, so they may wish to contribute. It was quite early in the morning, and so it was very quiet there, which is exceptionally unusual. But the advantage for us was that we were able to be shown around the urgent treatment centre by the nurse in charge. But before we got in the door, there's a theme developing this morning of signage. And the signage to get to the urgent treatment centre isn't that great. And somebody needs to walk it through again to make sure that you can find where you need to go. Even Lisa and I got very confused over this. The urgent treatment centre, when you arrive, you go through the same triage as you do if you come to A&E. And that's really important because it means that people go through the correct stream at that point. The consulting rooms for nurse practitioner consultations or for general practitioner consultations in the UTC are really fantastic facilities there. Very large rooms, very well equipped, and standing ready to treat people there. Because it was very quiet in the UTC, we then expanded our brief and went across to look at the ED as well, emergency department. And we were shown around there by the consultant in charge because, once again, it was a quiet morning. She was very complimentary about the layout in our ED, which is a horseshoe shape. And she said that is very good because it does enable her to keep a visible view on all the patients, and she can cluster the ones that need most of her attention in front of her. It has been very challenging over the winter when there are only 4 beds in the resus area, one of which is paediatric, and that has created problems as people have to cascade into the majors. The biggest challenge is staffing, especially nursing, getting nurses, a full roster of nurses. Unusually, is it unusual, Daniel, that the team is completely cross-site, the consultant team? So they do sessions at both St Helier and that, they said, works really well. They were very complimentary about that side of it. I asked to see the clinical room and to see the fridge. And in majors, in the clinical room, the fridge is not working and has not been working for about a week. And they commented that it does take a long time to get these things replaced. So I said I would mention it and see if by lunchtime there could be a new fridge on order for them.
But we should say that there is another fridge in the department,
yes.
which they are using, which is properly locked and the right temperature and all the stuff.
Absolutely, absolutely.
Is okay.
Yes.
I think the other thing to pick up is when Dr. McFarlane was talking about the great layout in Epsom, she was comparing it to the impossible to work out layout at St Helier. Wouldn't it be good if somehow we could get St Helier to look something like Epsom?
It's based on a horseshoe shape with the desk where she sits in front, and so she puts the most critical patient directly opposite her, and she can keep them under observation all the time.
Good, thank you very much, Elizabeth and Daniel. Let's move on to James and Rakesh, who went to surgical suite.
So I went to the surgical suite with Rakesh. It's a new purpose-built facility that opened in June of last year. I remember I tend to get in quite early in the morning, and a year ago I'd bump into patients wandering around the hospital looking very lost, not knowing where to go for their day case procedures or for their pre-admission to Swift ward. But now all patients come to the surgical suite. It's as you approach it, it feels bright, it feels clean, it feels airy, it feels like a purpose-built clinical area that is welcoming. There are 2 nurses there. It had a very calm feel. They weren't particularly busy today. We might need to look at why we weren't doing as many operations as perhaps we were hoping to do in terms of productivity. The patient sitting there, we had a chat with them. They felt that the communication leading up to their admission was very good. They felt well informed. They felt that they were being well looked after by the nurses. One patient mentioned that in the information that he was given for his arrival, he wasn't given a map of the hospital site, so he needed to ask a few people where to go, but the other patients all seemed to receive that information. There are 4 clinical assessment rooms for the anaesthetists and the surgeons to see people in very appropriate accommodation that feels clean and airy and big enough to do a proper private clinical examination if necessary and have a a conversation and just to make sure the consents are all up to date. So overall, it felt like quite a positive experience. The nurse, I think, took real pride and ownership of the area. The one negative that she wanted us to feedback, Trevor, was that they've got a very large TV that for the patients, sometimes the patients need to wait there for a few hours, and I think they've had some difficulty with the reception, so the TV doesn't work. And so some patients have fed back that they're a bit frustrated that they're looking at a blank TV screen.
Thank you very much, James. Finally, myself and Peter went to the labour ward, which is busy. A number of ladies in various stages of giving birth. We couldn't go into the operating theatre because someone was in there having a caesarean. So we were taken around by Diane, the matron. My comments really, well, I'll feed back once again to Trevor, and I'm sure he knows this, but one of the things about that part of the hospital is that it does get very hot, and it gets extremely hot in the summer, temperatures, in the 90s or even higher. And I suppose their plea is for, obviously they know nothing can be done about sort of a permanent solution, but for temporary air conditioning units to be on order, ready sort of from next week onwards, from when it's going to get hot. Trevor, you were going to say something.
Yeah, so I think we're acutely aware. One of the major problems is that the windows are rotten and are screwed shut, so we can't get any natural ventilation in there. I'm hoping in our part 2 of the board that we'll have a conversation and we'll be agreeing capital funding to address that problem. And hopefully, if we do that, we should be able to resolve it for the summer, this summer.
Thank you.
So just on this, the window subject on this side, the cost of sorting out the windows in Epsom alone, so there's the building maternity is in, and this one is over £2 million. Because it's not just the window you have to replace. You end up having to replace the entire frame and space in which the window is in. So it is, as ever for Epsom and Helier, something that seems quite simple, ends up being an absolutely massive task, and of course you have to keep the hospital going while you're doing it, so you can only do very small amounts at any one time.
Yeah. Well, thank you. I'm pleased it's clearly it's very much at the front of the mind of the people who work there. The other interesting conversation that we had with Diane was about perhaps a slightly more strategic one about how ladies want to use or would prefer, some ladies prefer to be in a labour ward with a bed and doctors on hand, and others are okay about the birth centre, which is about maybe 35-40% of the births. And the matron was very keen on being able to promote the concept of the birth centre, not just to the ladies, but also within the team. And I sort of got the feeling, I don't know whether Peter did, that there might be a little bit of sort of a requirement to just sort of make people much more aware, make some of the staff much more aware of the advantages of, potential advantages of a birth centre. I don't know whether Charlotte or Arlene want to comment on that.
Thank you, yes. We've just recruited another midwife consultant for normalising birth, and that undoubtedly helps promote the normalisation of childbirth in the birthing centres. When we come on to the integrated performance report, we'll talk about the increase in the caesarean section, and I think it's reflected nationally. There is a national push to reduce stillbirths and starvation of oxygen of babies at birth. The other complicated factor here is that the birthing centre is one floor down from the delivery suite, whereas at St Helier it's on the same level, so it's very easy to just transfer the lady into theatre should you need to, and that does impact on our birth centre rates here.
Yes. Any further comment, Peter?
So the other element we discussed was the kind of the, I suppose, the caring and the calm nature of the environment, and how the matron gets feedback from women on so after delivery, and about how that's much more immediate about you getting that sense of are there any issues that need to be addressed there and then, rather than waiting for them to move into complaint. So there's a very positive, constructive engagement with women through in that process. So I think that's the other element, other than just the physical estate issues, that I think the matron wanted to cover off. Thank you.
Thank you very much. Thanks everyone for doing that. Always very useful feedback. So welcome to this board meeting. A couple of apologies for absence. Martin Kirk, non-exec, is on a pre-booked, pre-arranged holiday this week, and Professor Ian McPhee, non-exec, is working in the USA this week, so they're not here. Otherwise, everyone, I believe, is here. Are there any new declarations of interest? Thank you very much. Let's just move on to the minutes of the previous meeting held in public on the 9th of Feb. And just asking for comments on those minutes to make sure that they're okay. So just quickly going through page 1, page 2, page 3, page 4, 5, 6, 7, 8, 9, and 10. Good, thank you. Update from me. Brief update from me this time. As you will all know, the NHS is still under huge amounts of pressure, and our trust is no exception. We've performed pretty well in comparative terms. We're still very much one of the best trusts in this area for A&E performance, and we've also performed well operationally and financially, so well done to the team for that. I think that clearly the announcement recently of extra money for the NHS, and indeed a pay rise, a pay increase for most NHS staff, are both very welcome, and it's really good for us to be able to finally be able to pay our staff more money, and I think that there's been a lot of very appropriate pressure being brought to bear to make sure that NHS staff do get a reasonable pay settlement. The only other thing I want to raise is that a number of you may be quite familiar with me keeping asking Kevin about when's our staff bank work with the other South West London Trust going live, and it's always been, next month, but it's actually happened. And so actually I'd just like Kevin just to give us a brief update on what it means and what it is and how it works.
So it's what we're calling a collaborative staff bank. So you'll know, most people will know that we use bank staff who want to work flexibly that then support our permanent staff, although our permanent staff sometimes do extra work through our what's called the staff bank, and it avoids us using expensive agency. So we're trying to increase the numbers of people that work on the bank so that we don't use as much agency. At this first stage it is focused on nursing and general nursing, and we've been working with St George's, Croydon and Kingston to create a system where we align when we put the rosters out, and we give lots of notice, and we do it at the same time so that people who work bank can have more predictability and know when they're going to work. And we've been working, which is the thing that has been delayed, on some new technology that allows nurses to look on their phones from the 4 different trusts and then book themselves into any shift in any trust after a period where the local staff have had the first opportunity. So Epsom St Helier staff will get the first opportunity to book into Epsom St Helier shifts, but equally if we can't fill it with Epsom St Helier staff before going to agency, there will be an opportunity from someone from Kingston or St George's to book in to that shift. We've only gone live with 4 wards in each of the trusts because of this problem about this new technology. But we then, after we've ran the first payroll and checked that it's working all right, we will then incrementally spread it out, and then we're starting to look at other staff groups that we would use it for. It's the first, Allocate, who were the company working with us, saying it's the first time in the world, they're claiming, that organisations who in effect could be competitors or working in different organisations have come together to allow staff in this collaborative way, and the rest of the UK are obviously looking at what we're doing.
The other thing that's really clever about this software, which has this catchy title of Allocate Me, is it knows who you are. So it only comes up on your phone with the shifts that you're actually qualified to do. So, and then because we've shared all the information about how we employ people across the 4 trusts, it's really easy for someone from Epsom and Helier to say, I'm going to go and work this shift in Kingston, and vice versa. So we've simplified it, we've made it really user-friendly, and sorted out loads of governance.
And the other thing, which has been very important but quite tricky, is we've also harmonised the pay rates so that we're not got a wage spiral by people competing with each other. So we've made agreement to harmonise the pay rates across those 4 trusts.
Thank you very much, Kevin. I mean, I'm really pleased that this has finally gone live. I think it will enhance flexibility, hopefully will reduce agency spend. I think it will be really important that you report back after maybe 2 or 3 months so we can see how it beds down and takes off. But, you know, as a, if you like, a pioneer in the country, it's really good that we finally got this one off the ground. That's it from me. Daniel.
Okay, so my report, as ever, is highlights from the weekly messages I send out. Actually, when you look at it, an awful lot happened since January. So starting at the top, so the CQC came and did their hospital inspection in the first working week of January. And then they announced, while they were here, that it was really very hard to inspect any hospital in January because of all the operational pressure. So they stopped doing any other hospital inspections. We've had the first draft of the report back. We have to send in all our comments today. There are pages and pages and pages of comments we have on their report. It does note in the first draft lots of positive progress in lots of areas, which is good, and all being well, it should be published in May, we think. Moving down onto the second page, Winter Heroes. So I'm really proud we did this. We wanted to acknowledge how hard people had worked over the winter. We asked staff to nominate members of staff who they thought had gone over and above the call of duty to keep patients safe. We had a big award ceremony, and Jeremy Vine came to compare it, facilitate it, and not only, of course, is he a great speaker, he also told the story about his own dad, who is one of our patients, which was very moving. And we recognised the achievements of well over 100 of our staff. At the bottom of page 3, we have an amazing sister on A5 called Pat Mendonza, and she got an invite to Buckingham Palace to recognise her huge achievements as a nurse over an awful lot of years in Epsom and St Helier. We published the gender pay stuff as required. On flu vaccine, we had our highest ever uptake of staff flu vaccine at 71.7% and got a commendation from the top of the shop for that. Then the Mighty team on this site, so they're our cleaning and catering provider, won an award at the Kimberly Clark Professional Golden Service Awards for great service. We've had conversations before about some of our medical training hasn't been as good as we had wanted it to be, but we have 2 very positive things to report. There's a new thing called a charter mark for training GPs, which is brand new, and we have been awarded some of the first charter marks in the country for paediatrics, obstetrics and gynecology and palliative care, and almost got there, and they will get there, but the ones that actually got it are orthogeriatrics and emergency medicine, A&E, sorry. And then Health Education South London, who are the people who assess whether we're providing medical training for the medical trainees after they've qualified and they're in their getting up to be a consultant level. Came and did a re-inspection and noted massive improvements in the quality that trainees were getting. So when you come to the risk register, we've actually managed to reduce the risk of an item on the risk register because we were at risk of losing trainees and now we're not, so that's very good. From the 1st of April, we have in-housed our non-emergency patient transport service, and that transfer has gone okay. Just on one floor below, we now have a world-beating service in prostate cancer. So there is a new technique where you can diagnose someone with prostate cancer within 24 hours. So we're at one-stop clinic. It requires a huge amount of diagnostic and kit to do it. There are 3 places in the world that are doing it: Epsom, Roehampton and Imperial. And it's going amazingly well at reducing or diagnosing people with prostate cancer more quickly. I'm sure it's going to be rolled out across the country and the world. It's been in the New England Journal of Medicine, and we have a consultant, Steve Gordon, who's right up there internationally doing it. I think it was £600,000 worth of kit we've invested in that the NHS nationally has paid for. Then Epsom Health and Care, which we've spoken about before, which has been focused on delivering better care for the over 65s, has now started on integrating the care of stroke patients. So we now have brought together the hospital team with the community teams for stroke, and we must be one of the first parts of the country that has a joint clinical director who's a consultant and a physiotherapist for stroke services. And the plan is to look after many more patients in their rehabilitation phase at home by the hospital and the community team in reaching together. And then we have a new idea. So idea is integrating Dorking, Elmbridge and Epsom Alliance. And that is our alliance we formed between the hospital, all the GP practices in Surrey Downs in the 3 localities of Elmbridge, Dorking and Epsom, and the existing community service provider called CSH to bid for the community services in the middle of Surrey. And we all decided to come together because the services had to go out to tender, and in a sense none of us actually wanted the private sector to have a chance of winning, but also because we had a fantastic new service model where we want to provide much more community-based care organised around GP practices. And I'm pleased to say we won the tender, and as a collective, and from the 1st of October, Epsom and Helier will be the host of the contract to provide community services in partnership with all the GP practices and Central Surrey Health. And since we won it, Surrey County Council have said, well, we'd now like to integrate social services properly with you as part of that. And Surrey and Borders, the mental health provider, have said they'd like to join in with mental health services too. So this could really be an amazing way of the whole health and care system in this part of Surrey coming together. Then JAG accreditation, catchy. So that is the formal accreditation you have to run an endoscopy service, and they had already re-accredited Epsom. They didn't accredit St Helier the first time because of the environment. We have sorted out the environment at St Helier, and now we have got the accreditation, so that's very good. We've begun to list out all the huge number of projects we've been spending money on improving the environment, and since we wrote this, the list has actually got longer. So when we do the annual review, there's even more things to talk about. Radio 4 came to do a programme about how complicated it is to secure the capital to rebuild your hospital, and they did a whole programme on capital in the NHS and featured Epsom and St Helier. We've got new retail facilities, so since writing this we now have we have Smiths on both sites and Marks and Spencers on both sites. The number of compliments from staff is just staggering. The 3 people this week have told me, Daniel, you might not get us a new hospital, but second best is getting us Marks and Spencers. I'm still going for the new hospital as well, but then we've spoken about the Sunshine Clinic, the brand new paediatric outpatient clinic. Was opened by some ambassadors from Chelsea Football Club and of course our very own Ruth. The Bearing Hope campaign that a family launched to improve the bereavement facilities at the maternity unit at St Helier. They raised all the money that they expected to really very quickly. So we're now on to creating the space that they've raised the money for. That's very exciting. We had the idea of we should get some activities on the wards, and we asked local retailers whether they would supply boredom-busting stuff to go onto the wards. Had amazing contributions, and there's now lots of puzzles, board games, and other such things on particularly the elderly care wards. There's a very glamorous princess who came to visit the children's ward. Then one of the local junior schools has decided that the fundraising that they should do for their school this year is us. We're quite chuffed about that. And there we go. So a lot has been happening.
Thank you very much, Daniel. Yes, a lot has been happening, and it always does and always will. Good. Let us move on to the Integrated Performance Report. I think we'll start with Ruth. Thank you.
Thank you very much. So, as always, we'll go through the pages one by one, and I will start with the mortality page, which shows a consistently positive picture in terms of overall trust HSMR, with a lack of variation between weekday and weekend HSMR, which is an important differentiator to look at. The report here highlights the fact that, like all NHS acute organisations in the country, we saw a spike in mortality in early January, and have actually undertaken an in-depth analysis of those cases, which has proved very helpful and actually has given significant assurance in terms of care and processes in place.
In terms of some of the operational quality measures, stroke performance is improving a little bit, and we hope and anticipate that the occupancy in stroke beds will improve further with the integration of care at the Epsom site. BTE performance, whilst not meeting the constitutional standard, has taken a step change for the better in January. This is particularly pleasing as it was an incredibly challenged month from a medical perspective with the surge in activity. And I'm hoping that this is the new whiteboards really making a difference in terms of the visibility for the clinical teams to understand which patients have or have not got an up-to-date documented VTE assessment.
Moving on to 1.3, the Trust has had a strong month in terms of good incident reporting, which is very important in order for us to learn lessons from when things don't go as well as they could have done. But given the operational pressures, has continued to be challenged in completing the root cause analysis in a timely way. The duty of candour picture, that's ensuring that those who have made complaints or whose care is the subject of an incident are kept informed about the process, is strong, but at 71.4%, there is further opportunity for us to increase this and be more open and candid with our service users.
Moving on to the nurse-sensitive indicators, despite the huge levels of activity. Thank you. Just moving on to the nurse-sensitive indicators, despite the hike in clinical activity, our safety thermometer and falls remain stable. You'll see on excuse me, the next page, care hours per patient day. This has taken a reduction, and that's because we've had a number of escalation wards open, and we've had to spread our substantive staff. What we did do is flood the wards with our clinical nurse specialists, matrons, heads of nursing, and myself, who work clinically, during January and the beginning of February particularly. I want to move on to infection prevention and control. We have reached the same level that we did last year with our 6 MRSA bacteremias. We're still waiting for one of the bacteremias it's with NHSI for arbitration. The hand hygiene audits continue to show an improvement, and that's sitting with the improvement plan that we have for infection prevention control. Moving on to maternity care, I draw your attention to the caesarean section rate, which you'll see in Epsom rose quite considerably to 41.7%. So Dr. Ramesh Ganapathy has done a deep dive into this, and we've found, because that is an abnormally high number, the number was contributed to because of the number of category 2 caesarean sections, which means a mother has to have a caesarean within 60 minutes to get the baby out at speed because there's either maternal or fetal compromise. That said, our number of elective caesarean sections has reduced. What we're doing is we're having a weekly review looking at every single caesarean, emergency and elective. And what we're going to do is feed that back through patient safety and quality, and Ramesh is coming with a report for the next one. I think it's fair to say that has been a national focus in the last 6 months on reducing the numbers of stillbirths and small babies who are born, and by monitoring fetal movements. So we are far more mindful of that now, and we are seeing an increase generally across the trust, across the UK with our caesareans. And I think that's...
Yeah, thanks very much. Let's take this moment to see if there are any questions from NEDs on any of the indicators that we've had so far.
I just wanted to comment that last point, that we are in PSQ keeping a close eye on the caesarean section issue. We had a report about that and postpartum hemorrhage earlier in this year, and we will be, as Charlotte says, having Ramesh back again. And of course it is reflected in the drop in the rate at the birth centres.
I have just seen...
No, not this part of the meeting, no.
I have just seen March's figures, and we've dropped 10%.
Oh, good. I'd just like to dig a little bit more into the TIA performance at St Helier, which has gone down quite considerably. Is there any specific issues there?
I think the absolute numbers are very low. This is the requirement for patients who are deemed to be at a high risk of, patients who GPs refer in who have a suspected TIA, who are at high risk of going on to have a stroke, being seen and assessed by a consultant stroke physician within 24 hours of their presentation to their GP. We are one of a few centres in the country that manage to provide a 7-day service for this. The challenge that this partly reflects is to improve the awareness and education for GPs so that they refer patients in a timely way to the service, and that they need to understand that we do clinically prioritise this, and we are able to provide the service if we have high-risk patients. So we need to work in partnership with GPs to publicise this more widely.
Thank you. Thanks. Let's move on. Lisa.
Thank you, Chairman. Under a patient experience, just to note on the friends and family test, we're going to continue to work on A&E. In fact, that's becoming one of our quality priorities for this coming year. We're working with HealthWatch. A questionnaire has already been designed, and HealthWatch are coming in to work with us to understand how we can make the experience better and improve it for our patients. And on maternity, they continue to see really high recommender scores, but the response rate is somewhat low. So we are working with maternity on different ways of engaging with mums and mums-to-be, and that is through using things like electronic means, which we don't do at the moment. So that's something that we will be going to see improvements on within the first quarter of this year. In terms of PALS, the PALS service over the last 3 to 6 months has done a most amazing job. We now have a PALS service open on both sites, and the numbers of contacts they're having each month steadily increases, and the guys are managing to deal with the volumes and help the numbers of people coming through the doors, the majority of which are just requests for information and advice. However, they are being able to help in terms of communication and information and discharge arrangements, so they're really playing a vital role now in supporting patients and our staff to prevent, if you like, people having to complain, so we're getting answers to people's queries really quickly. In terms of complaints, we are continuing to see an improvement in the response rates. And I'm really delighted to be able to report to the board that medicine and women's and children's for the first time have achieved a response rate of over 75%, and this is a significant improvement if you look back over the 12-month period in terms of the numbers that they have to deal with and the complexity of the complainants that they have to deal with. So that means we're answering a lot faster and helping people to understand that the care that they've received.
Thank you. Let's move on to Dan.
So to cover some of the operational performance outputs, starting with cancer, we've achieved the 2-week wait standard in January, and we report here a month in arrears for cancer standards. We've got some work going on at the moment to try and work out where we can overachieve, because there's some evidence that earlier performance against the 2-week wait standard correlates strongly with improved performance against the 62-day standard. So we're working where we can outperform that. We've met the decision to treat first treatment standard and again for subsequent in month. Our challenge has been against the urgent GP referral to treatment and the consultant upgrades. And to cover those collectively, the standard measures the month in which you stop or the treatment begins. So we've done a lot of work into those patients who've been waiting too long clinically and making sure that those patients receive treatment. And in doing that, what that means is you start a whole load of treatments, which then counts as a breach against the standard. So I think we've done the right thing, but that has affected our performance in month, and we'll see a similar position in February. Daniel mentioned the rapid pathway, so you can see the number of urology breaches there, and the number of urology breaches is starting to drop in February and through into March, where the early indications are that our performance is quite strong. We've also done a considerable amount of analysis about what's causing some of these, and the majority are due to complex pathways around the South West London Partnership and the Royal Marsden, and working out how we can see people and reach a decision even faster so that we can then transfer our treatment and make sure that we do the right thing by our patients. So I think we're starting to see the green shoots of that through February and into March, with improved lung pathways, urology, the rapid pathway, and again in head and neck and haematology and the crossover there. So I think there's an improving picture to come, but it's been a difficult month in January. To move through to RTT, we have continued the trend of struggling given the non-elective pressures, which mean that we've diverted resources away from our elective care pathways. That has seen our backlog increase against the referral to treatment standard. What has happened, though, in March is that has now reduced slightly, and the additional resource we're now putting into this, freed up by the non-elective pressures, is starting to improve our performance. And again, that's starting to bear fruit. We've achieved the diagnostic waiting times through a considerable amount of effort on efficiency work by the team, and that's been really impressive. And again, our elective length of stay, although there's a slight increase, I think that's normal variation and reflective of the fact that we're treating the highest acuity patients rather than dealing with some of the quick wins. Our last-minute cancelled operations continues to be a difficulty. However, we have tried to communicate to our patients that we are bringing them in and that they may not get a space in theatre, and asking them whether they're prepared to come in. So we're trying not to inconvenience people, but by pushing the limits, we have got far more work done than we would have done otherwise. So I think that's a reflective of the way we've communicated with our patients and talked them through.
Dan, can I just stop you there?
Yeah.
Can you just enlarge really and try and give a picture of the impact of the national, if you like, move saying elective work should be cancelled from January onwards, and how that's overall impacted us, if you like, for the period since January.
So we were asked to cancel all non-urgent, non-cancer operating, and all operations that weren't going to involve a day case bed. And then we were to also cancel clinic activity where that was not, where we could better use that medical resource to help patients non-electively. So what that has seen is a slight reduction in our clinic outpatient activity, but also it has meant that patients not coming in for urgent or emergency procedures or cancers, we've had to prioritise those carefully where they may require an overnight bed given the non-elective pressures, and that has meant we've had to reduce the amount of elective activity we've done, and clearly that has also fed through into our RTT performance as well.
And how long before we sort of catch that up?
So in terms of our what's called non-admitted, so those patients who are going to be treated on an outpatient pathway, We've already seen improvements in March, and I'm confident that the activity we're already seeing and have programmed in April will reduce that significantly in April as well. The challenge is that clearly our theatres are a fixed space, so we're now doing some work on theatres efficiency. So I think our non-admitted will improve rapidly. Our admitted, there may be a 4 to 6 month lag before we start to see an improvement, simply because we've got the limitation of our theatres. But I think the efficiency work and asking ourselves, is there an alternate setting? For example, in gynaecology, there's some work we've been doing in theatres that's actually better done in an outpatient procedure room. So working out which activity needs to be in a theatre, we can improve the throughput of people who actually have to be there. So I think we'll see an improvement.
Thank you. So from April, we need to change how we show this indicator, because whilst the constitutional standard remains, the thing that we are going to be assessed against is the total size of the waiting list in each, for us, so right across the NHS, going up, down or staying the same, where the government's priority is that it goes down. So we currently have about 30,000 people on the waiting list. So the measure will be about that indicator for the year 18-19.
Okay. Right. And then just to cover emergency care, the BBC reported last night that March had been a very difficult month for the NHS. This covers February, but I've pulled some data over the last few months. And I think of our the highest 6 months for admitted emergency patients, those patients who've come in through our accident and emergency and ended up in a hospital bed, 3 of our highest 6 months fell in the last 4 months. So it's been a really, really difficult period of time. And that's been reflected in our emergency performance, which, as Daniel has indicated, has held up well nationally, particularly for the performance of those people who go into accident and emergency rather than who come in needing an urgent treatment centre. And I think the acuity of the patients that we're seeing has been reflected in our length of stay, and also in the fact that we've had to open escalation areas, which has stretched our ability to deal with them considerably. And the signs for March, where we've seen that improve, are promising, and I think we'll reflect that in next month's board report. Delayed transfers of care have increased slightly in February. That's due to the social care system also having to expand and meet demand. And that's a reflection. We've been working very carefully with them to help support our patients as they move through hospital care into a social care setting. I think it's probably worth finally mentioning ambulance arrivals, which are up 5% in St Helier and 8% in Epsom against the same period last year. And again, I think that's just a reflection of the pressures that we've seen. And it's impressive to see that we've managed to improve our handover times in the face of that. So it's been a difficult but also a promising month.
I would just add, so in the BBC data from yesterday, which is March, so we were 22nd in the country for March and 3rd for London, and the 2 hospitals above us in London are, one is really small, it's the Homerton, and the other one is Chelsea and Westminster, who have just opened a brand new fantastic A&E department, which I helped get them the money for in their last my last job. So I think our performance is still pretty good for A&E.
Okay, so workforce, just on the first page, we see the steady fall in the vacancies, and myself and Rakesh have signed off the workforce plan for next year, so we won't see that increase at the start of the year in establishments that we don't fill. So again, we should expect to see a continuous reduction there because we're focusing on the recruitment. You'll see in the next graph that green line for the estates has been pretty steady challenge, and we've been looking for some time now about how we can convert some temporary staff to permanent, and Trevor's got a solution for that now, so that should start to come down. On the flip side, we've insourced the transport, and the private sector provider have transferred loads of vacancies, so that will flip it the other way. But on both of those areas, we're talking about relatively small numbers compared to things like doctors and nurses. You can see that we're maintaining our clinical workforce, but we continue to put pressure on reducing vacancies, particularly in nursing, medical and scientists, therapists, technicians. The agency trajectory, we've breached it but over the year we should still be within the trajectory. But again, as you'd heard earlier from the collaborative work, we're looking at medical agency staff as well with the other 4 trusts in South West London to try and make sure that we can reduce the agency expenditure as much as possible in doctors. The nursing net gain chart, which was previously actually in the section that Charlotte talks about, is now in here. A couple of areas to point out really. This month was one of the first months where we've seen a negative position for quite a while because our leavers were higher than our joiners. And so that's a couple of months now where we've got a higher level of joiners than we've been having previously, so we're focusing on, you know, what's the driver of that, and is there anything that we can do to pull that round. The joiners do fluctuate because we tend to bulk recruit, so that's not a concern at the moment, but we just want to really focus on that retention side. Sickness absence has come down, and actually I've got the March figures as well, which is 3.97, which is a whole percentage point reduction, which is relatively close to our target of 3.8. So again, just keeping the focus on supporting staff and getting them back to work. As you would expect, the main drop has been in coughs, colds and flus. A big area of attention for us at the moment actually is at the bottom of the second page in the appraisals, which is really disappointing figures. It reflects, in the clinical areas, it reflects obviously some of the pressure that the trust has been under. No real excuse, I don't think, in the corporate areas for not doing the end-of-year appraisals. We've taken an executive decision to extend that deadline to the end of May, but really now manage that down in terms of performance. That'll be a big focus in the performance meetings that happen in a couple of weeks' time. We also have decided that we'll focus on statutory manager training in Q2, rather than where we've done it in the past in the winter, so that we're spreading these out a little bit over to the year. But those are the 2 areas at the moment that we're putting a lot of focus on with the divisions, is the statutory manager training and the appraisals and the objective setting.
Thank you. Can I just go back to the nurse recruitment and, you know, more leavers than joiners? What is the current position on our, if you like, our nurse recruiting campaigns, particularly with overseas nurses who we are trying to attract? And what are the issues that hinder us from recruiting as many as we would like?
So our overseas nurses campaign continues, and we've only ever really had about 5 coming in a month, because they change the regulations quite regularly nationally.
Is that the language regulation?
It is, yes. And the testing, the way we test them in English has now changed 3 months ago, and I think we're seeing the impact of that. Brexit has completely wiped out European recruitment, and that's nationally felt to be. I had a conversation with Ruth May, and she agrees, so that's a nationally held view. Our local recruitment has improved, as I've seen it over the last sort of 18 months, and we're getting far more people applying for jobs, not just from South West London, but across the country. So I'm hopeful. And our time to hire for nursing has reduced. HR have really supported us well with that. So, yeah. 87.
So I think just to add on, you asked about nursing, but the area with that we're trying to put pressure on Home Office actually is around the medical. So they've increased put the bar higher, which means that we've got people in the pipeline that are ready to start that we can't get visas for. And so, no, it's not a language. There's a point system for the visas. And they've actually increased the number of points that is required to get a visa over the last few months. And so there's quite a bit of pressure from the NHS to try and influence the Home Office, but that's still the position at the moment. So we've got a few doctors. It's not a lot of doctors, but it's sort of 8 or 9 that could have been on the wards that are waiting for visas. So we're looking at how we can work that as well. But that's, again, a national issue that lots of trusts have got that problem.
Thank you. Any more on Kevin? Please.
Thank you. Website, again, And it's good to see that vacancies and work experience continue to be the most searched elements of the website. So the activity we're doing with HR to continue to use that as a vehicle to recruit from is working quite strongly. My favourite top tweet, must be of the year, was most popular tweet during February was the Happy Chinese New Year one, and our pet dog, who comes onto our wards and supports in terms of therapy. And then we've had some really positive media coverage, particularly looking at the estates, but also about one of our young patients who made a remarkable recovery from a very rare illness, and that got a very lot of coverage.
Thank you. Rakesh.
Thank you, Chairman. So on the finance pages, the board will note that there are two indicators for income and expenditure, and the first one is how has the trust performed financially before we receive STF, Sustainability and Transformation funding, and that's the first metric. And against that indicator, at the end of February, the trust was 800,000 better than we were planning to do, and I think that's a really key indicator. The next indicator on income and expenditure is after we receive this funding, and the funding is predicated on two indicators. One is hitting the financial control total, but also A&E. So we know A&E, we did not hit the target for the first 3 quarters, and therefore we're 1.5 million behind where we want to be. But I think the board should recognise that the first indicator before STF is the one that NHSI look at as financial performance. Against the cost improvement program, we had a cost improvement plan to make efficiencies and savings of £15 million. At the end of February, we delivered 11.2 of that. So a shortfall against that. We had a very, very ambitious capital program, marshalled primarily by Trevor and his team. And the initial plan was for £41 million, but there were a number of things that were deferred into the new financial year, 18-19, and the trust is now forecast to spend £28.4 million. And in my experience, having worked at other trusts, that is a significant investment, and there's a sizable investment in the coming year as well. Cash is a very key indicator, as I've said previously, and as we work on the final year accounts, we will be having a cash holding of around £5 million by the 31st of March. And the better payment practice code is important to us, as I've said previously, and we maintain that 92%, which I think against other trusts is a better indicator, better performance.
So just on the capital, £28 million spend is £10 million more than we've ever spent ever in a year in Epsom and Helier. So it is a massive achievement to have delivered so much improvement in one go. But you're going to beat it in 18-19, aren't you?
Yes, that's the plan.
Good, thanks. Yeah, I think Rakesh, well done on the financial performance. I mean, in a very tough environment where we've seen, lots of other trusts fall away, we've managed to keep on target and get our STF funding, and I think it's a great credit to the team to have done that under such a high degree of pressure over the last few months. So well done on that. Peter, risk.
Thank you, Chairman. So the risk register has been reviewed at the last Performance Assurance and Risk Committee. I just want to highlight 2 or 3 material changes to it. The first one that Daniel's already covered. So for the benefit of the board, it's been greyed out to show that it's on its way off the risk register, but that risk has materially been reduced in relation to the HESL visit and the way in which we support our trainees, particularly in elderly care. So that's one. The other one I wanted to highlight was when we were on the Labour Board this morning, Diane was wearing her Badgernet badge because she's one of the super users for the new Badgernet system. It's still on our risk register because we've not yet fully rolled it out, but once we have finished the rollout of the new system, that'll be another risk that we can remove from the risk register because we'll have addressed it. So, and then to give another example where where the risk register demonstrates how we're using it as a tool to manage the business. So we'd put the non-emergency patient transport service on the risk register some months ago because of challenges over performance with the previous supplier. We've now brought that in-house, as Trevor has discussed, but it remains on our risk register for the moment because it's only week 2 of that service, and we need to ensure that it's robust enough before we de-escalate that risk. So those are just some the specific examples. There are 1 or 2 other modest adjustments to the risk register, but we will have a fuller scrub of all the risks over the course of the next month when we come to sort of talk about risks to delivery in 18-19.
Thank you. I mean, I think Peter's reminded me about the software change on maternity. I mean, it sounds like a small thing, but it's actually a really big and important thing because the system we've been using for years is essentially now not supported. We're going on to one which is in common use amongst various trusts, and I think just sort of general, if you like, housekeeping stuff like that, like keeping up to date with the latest software is really, really important that we do that. Thank you. Excuse me. So, there are various board committee reports which reflect the minutes of various board subcommittees. If any of the chairs want to raise anything specific from their board committee report, now's the time to do that.
I just wanted to draw attention. My report covers 2 meetings that we've had since the last public board. And I just wanted to point to the fact that in February, we had a report that we'd requested about stroke, because clearly that's been an issue that we've been concerned about on the IPR for some time, and it still isn't solved, but we were assured by that report that the changes that are in train will materially improve the performance on stroke. And similarly, in our earlier, we've got another April meeting, but our beginning of April meeting, we had a very interesting presentation from the new infection control doctor, which was comparing our performance not just with our previous performance, where we show huge improvement over the number of years, but also with others. And it did raise a few issues which we're going to, we've asked the doctor to look at again and in more detail and discuss with colleagues and come back to us. So that's something that we're actively looking at, as well as all the usual issues that this committee covers in its very long meetings.
Good. Thank you. Any others?
Lawrence, if I may. Yes, I just wanted to touch upon some of the things that we had spoken about that have been touched upon before. So the medical workforce, I think that this is a particular challenge, and we've created a plan, if you like, to tackle this either through overseas recruitment or associate doctors, associate specialists, that kind of. So we'll be tracking this through POD on a regular basis, and as and when we make progress, we'll probably bring it to board. There are a number of other smaller people-related issues, related to a presentation we were given the last time by the Guardian of Safe Working, which also dovetails into the HESL issues, and we have now invited, if you like, the DME and the Guardian of Safe Working to the pod to ensure that we have oversight of these kind of issues before they go to HESL.
The DME being Director of Medical Education.
Yes, sorry, Director. And POD being People and Organisational Development Committee. We are also working on the staff survey and the results from the staff survey. So what we've decided to do, and Kevin can chip into this, is to have an offsite to really step back and look at, if you like, the whole HR strategy and how we're dealing with these various people-related issues, and to kind of have a holistic approach to this. I don't know if you want to say something about that.
I think that's what it is. It's some protected time to stand back and say, how are we approaching the workforce and what are the priorities really for the next 3 to 5 years, that then builds a plan.
Good, thank you. Peter, you're going to take us through corporate priorities.
Thank you. So before we get into the priorities themselves, I think it's important to set out some important bits of context. So in line with national planning guidance, we are required to produce a refresh of the plan we produced last year, which was technically a 2-year plan. We're in the process of that, including the contract negotiations, getting that approved by NHS Improvement, our regulator. So we're not quite yet in a position to publish formally our full plan, but we will do so by the 30th of April in line with the national guidance for all plans to be published then. So we're not yet in a position to talk through that in the detail today, but I just wanted to signal that the full detail will be available on our website by the 30th of April. So that's the first process point. Shall I carry on with
Yes,
with
please
Pat
do. Yes. The chairman will be back in 1 moment.
Great. So that's the piece of context. So what we have been doing is looking at refining our strategy ever since we first published our 2015 to 2020 strategy in March 2015, and our broad strategy remains as we articulated then, to keep the broad range of services at both Epsom and St Helier sites. So that's consultant-led 24/7 accident and emergency, the maternity, the inpatient paediatric services, with St Helier continuing to have a specialist focus on emergency care, and for Epsom to continue to have its focus on planned care. We also said that we would continue to work with GPs to provide significantly more care in community settings so that people only come to hospital when they really need to, and our strategy continues to deliver that. So winning the adult community service bid in partnership with others is very much in line with our core strategy. The other component that we've sought to achieve this year is to hone down the number of priorities we are saying that we must achieve. So colleagues will recall that in the current year we have 25 priorities against our 6 objectives, and whilst those are all very important components, that's quite a lot to kind of hold in one's head. So we've refined that further to have a single statement against each of the core of our objectives, which remain the same. So I think depending on the amount of time colleagues and chair or vice chair wants us to spend on those, perhaps it might be helpful for each of the kind of executive leads just to say a little bit more about what each of those components are. So if Ruth, do you want to talk through the deliver safe and effective care, of what we mean by improving the care we provide to our sickest patients?
So many of the things we will be doing in 1819 will be familiar to those of you who are regular attendees. We will be continuing to prioritise our focus on sepsis care, to deliver 7-day-a-week consultant services and on-site presence, developing our critical care outreach team, and further developing and further embedding our managing acutely ill patients policy. So they are the key channels which will allow us to care most appropriately and adequately for our sickest patients.
Great, thank you. Trevor, do you want to talk about what we mean by investing around £30 million in our states? We've alluded to it a few times already this morning.
Sure, thank you, Peter. I think, obviously, subject to board approval of our capital plan for 2018-19 in next private part of the board meeting, we're looking at significant investment, and predominantly we are doing continuation of work over at the St Helier site. So we're continuing with the phase 2 of the refurbishment of the external facade for B and C blocks. So that's the windows, roofs, and the walls. And we're looking at still delivering a new ITU HDU facility, another key thing, and a new surgical ambulatory care facility. But predominantly our focus will be changing to the Epsom site. We've already spoken about some of the window replacement work that we want to do, but we do know that we want some work around our old and failing boiler plant, which provides heating and hot water to the site, and that will focus on providing us new, or de-steaming the site, taking the steam away and putting in a new combined heat and power to make it more energy efficient and save us money. We are looking at re-providing some of our therapy space into Langley Wing just across there, to make that more fit for purpose and linking in with our stroke unit. And we also want to be providing some, relocating some facilities, such as our oxygen plant and showers and facilities for our staff, and looking at how we re-provide car parking on the site.
Great, thank you.
Not forgetting the creation of a brand new outpatient building at the back at Woodcote Wing, and refurbishing more of that building over there to end up with, in the end, not for next year, but the year after, a link bridge between here and there, so you can actually get to it without going outside.
Yeah, I think as keep it point, the outpatients at the moment, we have very much 4 or 5 different outpatients dotted all around our facilities, and we're looking at Woodcote Wing, first floor and second floor, becoming a central outpatient facility. And we're looking at significant investment next year to deliver that.
Great, thank you. Dan, do you want to cover off the number 3 about responsive care?
So I suppose the slightly simplistic version is we've got plans in place to start improving our performance against the 3 key standards. In terms of accident and emergency, the 4-hour hospital emergency access standard, we have a series of data analysis that tells us where some of our particular challenges are, and we're looking for either procedural or staffing solutions to improve those, as well as working with estates to work out whether we can improve the layout of the St Helier ED in particular to make it more user-friendly and look a bit more like the Epsom ED, which should improve the ability of our staff to manage the patients. In terms of cancer, I've already alluded to some of the work that's in train, particularly in terms of seeing patients within 7 rather than 14 days, and introducing as many straight-to-test pathways as we can, so that we're not wasting time bringing patients in for a consultation, sending them for a test, then bringing them back again. And also working out where we can review patients virtually to improve the speed of our decision-making, which will also benefit the speed at which we can actually begin the treatment. And finally, on RTT, again, the same procedures are in place, both in terms of working out where it is we need to do extra activity or where we need to recruit people to improve. We've got a detailed subspecialty outline plan, which is already delivering the April components of it. And in part also working out where we can change the patient's pathways. I've mentioned again straight to test, but also a move towards virtual clinics so that clinicians are making decisions faster without needing to inconvenience patients who don't actually have to come back and see a clinician. And actually, if it's just reviewing a scan and a test, where is it we can make that happen faster? And we note that all of those things will reduce both the overall size of the waiting list and should in turn improve our backlog as well.
Rakesh, you covered the
Peter.
financial sustainability objective.
So in the financial year just ended, 17-18, one of our short-term objectives was to hit our control total set by our regulators. For 18-19, we still have that as an objective. We've been set another control total, and we still, that's a key objective to meet. However, we've sort of broadened it for the coming year, and one of our key objectives is to improve our underlying deficit. And in broad terms, that underlying deficit is defined by what is our financial performance if we exclude all one-off costs and all one-off expenditure. So it's a better indicator of the financial health of the trust. And our key, and we have a key objective to improve that from this financial year to the next. And that is a theme that is running nationally across all trusts and coordinated by our regulators.
Daniel, do you want to cover working in partnership, or shall I do that?
I can do this bit. So we've got 3 big things going on. So we've launched. Oh, do you want to do it, really? Don't you? You did. Sorry. Go on then. You do it.
Sorry, okay. No doubt you'll do it better than me. But as Daniel says, I would say there are 4 key components. The first one is the Sutton Health and Care Service, which we've alluded to several times over the last few months, where we are seeking to bring some of the benefits of Epsom Health and Care collaborative working, particularly for the over 65s, to Sutton. We've in Epsom, we will continue with the Epsom Health and Care work. That's expanding into the stroke services, which was in Daniel's weekly message update at the beginning. You've also heard about the Surrey Downs Adult Communities contract that we now need to mobilise, which is, all of those are really key to us delivering different ways of working to ensure that patients only come to hospital when they really need to, not only helping with flow through the hospital or those attending at ED, but also making sure that it's the right patient experience for our patients and helps to deliver wider sustainability for the health economy. The fourth component is around us and our strategic outline case for the long term, which the board has approved the SOC in December meeting. There's still much to do to get decisions through the wider health system, and there will be no doubt a lot of discussion about that over the coming months. You'd like to cover off on that? Would you like to do number 6 then, about being well led? but you can do the first part, and perhaps Kevin would like to do working in partnership.
So we're clearly going to have a lot of actions that result from the CQC report when it is published. So we need to make an action plan to ensure that we develop those. And how are we going to improve staff satisfaction, Kevin?
Substantive staffing is still the bedrock of quality, performance, finance and staffing, so we just need to keep the pressure on that. We heard from Aruna earlier about the staff survey, and so the strands there are about people management, the staff compact, so that we get some common understanding of the behaviours that we want in the organisation, and then getting more regular feedback from staff, so that builds the confidence of staff to give us feedback, that then builds into a better response rate to the staff survey. And then last but certainly not least is the equalities, diversity and inclusion, and so now having the equalities manager building on that work to really address the issues that people are telling us in terms of feeling discriminated against or not equal access. So those are the focuses of that area.
So in short, we are keeping with the same broad 6 key objectives that we've set ourselves over the last few years. We're being much more focused on the things that we're going to do to deliver against those, and we will use our monthly integrated performance report and the quarterly board assurance frameworks and the corporate risk register as the key tools through which we'll both monitor progress and key risks to delivery. So we'll continue to use the 4 key components of our challenges around strengthening staffing, the variability of care, the quality of our estates and infrastructure, and our finances as the 4 key planks of how we'll use our corporate risk register over the next year.
Thank you very much, Peter. Comments on this, because clearly, focusing our corporate priorities down to 6 is, it was a significant effort, and I know it went through all sorts of committees and meetings and workshops and all sorts of things to get to this 6. I suppose my question is are we, as if you like, the board, are we confident that all of the bits of the organisational divisions have got the buy-in to this through the process we've taken to get here?
So I think the buy-in is there. So one of the, as you alluded to, Lawrence, so we worked through this both at board level and with the Trust Executive Committee, which includes the heads of clinicians, of doctors, nurses and managers from across all of the organisation in refining the list down to kind of what do we really need to focus on to make a real impact in 1819. So I think that element of buy-in is there, absolutely. I think the other element to flag is that as an organisation, we fully kind of realise that as with the rest of the NHS, it is challenging to deliver on all of these components simultaneously, given the operational pressures, the workforce challenges, and the financial environment in which we need to operate. So these are, even though you could say it's a simple table, there's 6 things in it, they are all extremely challenging to deliver. So we think we've got it just about right in terms of the stretch and deliverability. There's clearly more we need to put in place over the next few weeks to ensure that there are robust milestones and plans to ensure that we make the progress that we need to. So this is the start of the year component rather than it's not all yet lined up, but we'll bring that back to the board along as we kind of go through the first quarter.
And that's my follow-up, which is about how are we going to monitor and check progress against the actions and the milestones.
So I think we will continue to use the trust governance infrastructure. So the board subcommittees will play their critical part around patient safety and quality, the People and Organisation Development Committee, the Finance Committee, the Performance Assurance and Risk Committee, and indeed the Audit Committee playing its role too, is part of the way in which we continue to run the business, will be the way in which we ensure delivery. So there will be an element of detailed scrutiny at each of those committees for those key components. Park will take an overview of broader risk as well, and then we'll bring all of that back to the board, certainly through the monthly means that we review both the IPR and the corporate risk register, and then there will be a more formal stock take each quarter through the board assurance framework.
So I floated the corporate priorities with the nurses and midwives at our Nursing and Midwifery Committee, and they were all absolutely signed up to this, and they said, actually, what their job now is how does that resonate with the ward managers? Because if we get this right, our CQC actions will be complete and our staff survey will be much better, and the midwives gave a very good example. Well, that means to us this. So I'm very confident that this is a good set of priorities.
Thank you. So formally the board is asked to agree that these are our priorities for 18-19.
Good. We agree? We are. Good. Thank you very much. Thank you. Next item, contracts over 50,000.
Thank you, Lauren. So this is for information and standing items. So in February, we awarded 4 contracts greater than £50,000. All of them followed due process in terms of procurement. They were either procured through a framework or a local tender process.
Good. Thank you. In that case, is any other business? Any board member? In which case, thank you very much. That's the end of the board meeting. We've got our next public briefing on the 11th of May, our next public board on the 15th of June. And it's now opportunities for people to ask questions. Sandra, your hand's up first. Please go first.
Thank you. Just a comment before I ask you a question. I think it's very telling in your communications and engagement section. You highlight as a major positive for the Trust the fact that there was a Radio 4 programme on which concentrated very heavily on what's wrong with the Trust, what's wrong with your estate, how the buildings are falling apart and the boilers are appalling. I think it's very telling of your real motivations that you see that as a positive thing. I would have thought you'd be indeed ashamed of the state of this estate and how you've let it fall into disrepair. And it highlights very much your other plans that are going on. You have employed an estate agent, Savills, and you paid them £20,000, and you've used them to write to Sutton Council reinforcing your demand that Sutton Council should allow the change of use of the land at St Helier and take it away from being restricted to healthcare and allow you to sell it, the buildings and land, for housing. You are also, apparently, selling land at Epsom, surplus to requirements, in an area where the population is set to grow by about 24% over the next 20 years. And where you are clearly already severely overstretched. You've been talking about failing to hit all the targets this morning because of severely sick people. You're failing already, and yet you are selling land. You're demanding that Sutton allows you to sell land at Helier against the long-term demarcation of that land for health use. You're selling land at Epsom. You're not selling the family silver, I would suggest. You're selling the family kitchen, bathroom, and more importantly, the bedrooms. You are selling the very foundations of our local health service as part of the sale of the National Health Service as under the Naylor Review. This is criminal. People will die because of the actions you're taking here, and I think you all ought to be ashamed of yourselves.
Yeah, that's it.
Yeah.
So let's do a double act between me and Trevor. So firstly, you have been a resident in our catchment for decades. You have seen how there has been no investment in Epsom and St Helier hospitals for a very, very long time.
Yes, I've seen you give money back too that you were given to rebuild, and you gave it back
So the trust has never given money back.
Yes, you had 129 million
so-
to rebuild St Helier, and you said it didn't fit in with
So-
your long-term plan.
So that had
You could have done it 5-10 years ago.
so that is a completely separate issue. It had nothing to do with nothing to do with Epsom and Helier. The point remains. The key point is, Sandra, as you know, we have had decades of not having investment in our buildings, and that is why they are so bad.
Agreed.
Right? Under this leadership team's watch, we have really flagged that issue as it is completely inappropriate. And we are embarking, and now have embarked, on the biggest investment in our buildings the Trust has ever had.
Just before you said
And we got confirmation just a few weeks ago, finally, because we've been asking for this for the best part of 2 years, for £100 million of capital spend between the year we've just finished and going on to 2020. That's huge. That will enable us to repair nearly all of the critical infrastructure issues on both hospital sites, which it is obvious to everyone there is a bigger spend is going to be needed at St Helier than at Epsom, you can just see it by looking at the buildings. And as part of sorting out the critical infrastructure, we're also able to invest in improving a huge number of the environments in which our patients are seen, as witnessed on this site by the brand new paediatric and maternity outpatient department. The fact that the A&E on this site is going to be bigger by a third. So let me answer all your questions. So the first one is, I would be absolutely confident in saying this leadership team is leading the biggest investment that Epsom and Helier has ever seen. So let's do that bit first to get that on record. Let's get the next bit. Is how have we got the £100 million worth of investment? So some of it is the normal capital that we get given every year. A really big chunk of it, £25 million, is a new capital allocation to Epsom and Helier from the centre. And the third bit is, yes, we are and have been selling land that the Trust is not using for clinical purposes, can see no need to use for clinical purposes in the future. So are you going to let me finish, or are you just going to interrupt?
Well, I'd like you to tell me the truth.
Yes. Well, if you let me finish, I'll tell you the truth, because that's what I'm doing. The decision that we are going to hopefully make in the next part of the meeting is there land on this site that we don't think that we will need in the future. And in making that decision, we have taken the whole 2020 to 2030 strategy, where we said that you could build a 400 to 500 bedded new critical care facility on any one of our 3 sites. You could do it at Epsom, you could do it at Sutton, and you could do it at St Helier. And we are absolutely committed to ensuring that there is the land to do that on all 3 sites, whatever happens. We have also looked at all the services that you would want to put in every scenario onto the 3 sites. And in particular, we currently have a building over there, quite a nice 1970s building, that since the Surrey and Borders Mental Health Trust vacated most of it, it is not being used. So we have a fantastic facility to re-provide great healthcare facilities in on this site. We also have a facility at the back, Woodcote Wing, which we are turning in. That was almost derelict 2 years ago. It's already got a new eye service in it, a new cardiology service in it. It's got the Orthopaedic Centre's research unit in it. It's about to have almost the whole of this site's outpatient facility in it as well. There are some buildings on this site, as were at Sutton, where they are in a really bad state of disrepair, so if you look over there, there's a house behind that chimney that is sitting in a car park that is unusable. When we have replaced the chimney and the boilers with a combined heat and power plant, you don't need the boiler plant. And it goes on. There's an accommodation block which has been condemned, which we can't use because it's not fit for purpose. And you think, what is Epsom and Helier going to do with that? the agreement we've got from the centre is if we can release surplus land in the normal run of events, because we run a large deficit, what should happen is if you get a capital receipt from releasing the land, the money should be used to pay off your deficit. So you get a one-off benefit.
You sell the bedrooms.
Stop.
You sell the bedrooms to buy today's dinner. It doesn't make sense.
Let me
know that.
It makes perfect sense. So what would normally happen is that you'd only get given the money to pay off part of your deficit. Because we have been flagging that there is a massive building issue in Epsom and Helier, we have managed to get permission that not only can we use the money to pay off the deficit, we're then getting the money again to invest in sorting out the critical infrastructure. And that has taken a long time to agree, because it is enabling us to manage the financial position in the here and now and ensure that the buildings are getting the investment that they have been so badly neglected in for decades in the past, to keep them safe to where I hope we get to is we are going to get our new big new critical care facility. And I'm going to say we're going to link back to the point about
not big.
And then let me.
Yes. Not big, sorry. Thank you very much.
So we will end up with the same number of beds in total as we currently have under every scenario. Let me just. I'm just going to go back to your first point and then hand over to Trevor for the Savills point. So. Actually, it was massively helpful to feature on the Radio 4 programme about capital, because you will have heard...
It was positive to say how awful it is.
You will have heard that 2 weeks ago, Jeremy Hunt said, when he announced a £750 million capital investment in the NHS, that every year the government is now going to announce for one big new hospital build to be given permission to go ahead. And the one for this year is Shrewsbury and Telford. We need to get Epsom and Helier to be the one for next year. And the more high profile we can demonstrate that we need the investment and at the same time demonstrate what an amazing group of individuals we have in this organisation working so hard to deliver great care, the better. And as a result of that Radio 4 programme, we've had lots of interaction now nationally about capital. I'm going to sit on a round table with the Department of Health about how to how the capital gets allocated in the NHS. And one of the positive things in all the work that the clinical commissioning groups are now doing to hopefully get to a public consultation is there is now an agreement there's going to be a joint piece of work between the CCGs, Epsom and Helier, NHS Improvement, our regulator, and NHS England, their regulator, about what are the capital sources that we can use to build our new hospital. So we are edging ever closer to getting to the point where there is an agreement from the system that there will be a big investment in Epsom and Helier.
So implementing the Naylor review, which is bribing hospitals to sell land and giving you 2 for 1 to build houses on hospital land. And they're not making it on hospital land. The population is increasing by 24%.
So I think I've answered all of the points you made, apart from the Savills one. Let's let Trevor do the Savills one.
Interesting.
So I think it's interesting point. First of all, the work that you've seen around the Savills work is that we've employed them to undertake a number of work for us around our estates and look at how we maximise the value of any selling of land for the public. So the work that Savills have done for us is a lot of work around the Sutton Hospital site, and tied into that was the London Borough of Sutton undertook a consultation around their local planning, their local plans. And there's a number of areas that they picked up. There was the Sutton Hospital site, there's the Sutton Town Centre. Another part they picked up was the Rose Hill and St Helier Hospital. Now, the Trust has a duty to ensure that we put in a response to that planning consultation, and as part of the work that Savills is doing for the Sutton site, we also asked them to put our representation in there. And I think we are very clear that we don't know what the future is going to be, and what we asked was that there was a option in there that we had a potential partial use of the St Helier site for residential.
Well, actually, Sutton said you don't have a clear view, and Savills said, oh yes you do. Under STP you've got a very clear view. In other words, you're intending to sell the land. The council disputed your clarity of view. You insisted you had a very clear plan, which is called STP.
So if we take the contents of that conversation properly, what the council was saying is that the NHS doesn't have a overall plan around the future of healthcare services in West London. What Savills has said is that the STP does have a clear plan, and that said nothing about selling off St Helier Hospital or any land.
Was to reduce the local acute hospitals from the current 5 down to 4 or 3. I think the plan's very clear. You're intending to sell off our hospitals, and we will not let you do that. Because we will die if you do.
Okay, so let's just put this little bit back in context. Every local authority has to have a development plan for its area.
Yes.
Sutton Council has just produced theirs.
And that's always they say this hospital,
Okay.
the Helier Hospital,
Right.
must be reserved for health use.
So what happens
Not
next
right.
is when the council produces their development plan, they consult on it with the people in their area, and then they give that to the planning inspectorate, which is a part of central government, and the planning inspectorate then challenge the council about have they got the right plan. And as part of that, you get the planning inspectorate have a process where all the big landowners have to contribute. And what we said to the inspectorate was, if there is ever a time when we don't need some of the land at St Helier for healthcare facilities, could it be designated as housing? So it's all a hypothetical thing that we were duty bound to ask as a landowner, and the
You're not the landowner.
and
No,
we
you're
are
not the landowner.
we are the landowner.
So
We both own parts of the site, so we can only ask about the parts of the site that we own, and we got a very clear steer back from the council in request to our question, which is now is not the time for you to ask that because there is no agreed plan.
Wait
Fine.
till after the election.
So it's just like we've just been round a piece of bureaucracy that we are obliged to go round, where everyone expresses their for their own interest, and as it currently is, St Helier remains designated to be a hospital, and you will notice that we have declared none of the land and have no plan to declare the land at St Helier surplus.
But you are in Epsom.
Sorry, may I pick up on something you've been saying? Obviously, I believe under the Naylor regime, and obviously all the NHS trusts are working under that, you have got this obligation, that's unequivocal. In fact, the Prime Minister last March, April time in BBC broadcast to confirm that the government was behind it. She said it to Andrew Neil, as you probably know. My question is as follows. What's the process? I don't think the trust in isolation can deem itself available to sell land without some higher authority blessing it. Or am I wrong?
So you're right, there is a process, which takes quite a long time, which we hopefully will kick off later. So what happens is, if we declare a piece of land surplus, then we have to get the support of our regulator and also the healthcare commissioners to say, is that an acceptable thing to do? Right. And then you go through a process of the first people who can express an interest in buying the land is the public sector. So there's a priority purchase scheme, essentially. So Epsom Council or Surrey County Council or one of the other healthcare providers could come and say, or a housing association could come and say, we would like the land first, and providing the amount of money they're prepared to pay for the land is the market value, they get it. And then if there is no public sector purchaser, then you go to the private sector. So I don't think we'll have got to getting through all this process to see if we end up in the private sector purchaser till the autumn, and I don't think we'll actually have completed a transaction if we make a decision that we're going to declare it surplus until the end of this financial year, which is very good news because we've got, if we do decide to do this, a huge amount of money to spend to re-provide the mostly non-clinical services that are in the buildings that we need.
So does that actually mean, with respect, that you've already got your regulator approval, or have you not approached it?
So one of the reasons why we can't publish the operating plan for the year is we've put it in our operating plan and our regulator is considering it.
Right, so that's pending. So then it goes to your health commissioners.
Yeah.
And that's not been approved yet?
No.
Right. So the public actually doesn't get any say in this at all. You don't need to do a consultation.
Correct.
You do it as a trust. Once
Correct.
you've got those approvals.
Yeah.
It's a fait accompli. Okay, I understand that now. The pecking order you referred to, which is obviously public authorities initially, then you have secondary people, housing trusts or whatever. In that context, supposing you've got a health trust, housing trust, who wants to pay more than the council wants to pay, where do you go with that one?
So we'll go out to the public sector, and there's a deadline that everyone has to respond to. We publish a criteria of what the criteria in terms of quality, what the proposals are, and cost, and we'll have a criteria that we'll then evaluate all bids against. But how, in effect, the council would probably be a higher priority than a housing association.
I know, but Dan has said that's the case, but what I'm saying is, let's take some numbers off the air. Let's say the council is prepared to pay 10 million. Let's say a housing association, who desperately wants to get into the arena, pays 15 million. What does the trust do? Does it go for the 15 million or the 10 million?
So the trust will look at, the trust has an obligation to provide, get maximum value for that land, but as part also in that process would have a quality criteria, so housing versus what the council proposing to use the land for, and imagine they'd want residential or some sort of care home.
Right, so it's not axiomatic that the first person in the pecking order will get it.
No.
Right, that's what I wanted to achieve, thank you.
And will Savills be used to sell the land? Because they've just had the biggest sale of council housing ever, Savills have handled. Are you going to use them to sell our NHS land?
So if the Trust Board approve the land surface requirements, the Trust Board will need some professional advisors to support it through that process, and that would probably be Savills.
Yeah.
I find it rather strange that you can't afford to spend money to fix windows and facilities in a hospital that is actually meant to treat patients. You can spend money on Savills, you can spend money on Marks and Spencers and WH Smith. It seems remarkably contradictory in so many terms, certainly in terms of the patient first principle.
So just on this, you're really muddling things up here.
Possibly I'm joining up thoughts.
Right. So Marks and Spencers and Smiths are actually helping our financial position because they're paying rent for the space that they are
Which are not
using.
used to treat patients anymore.
But the money that we're getting from their rent is new money to us. So when
It's being spent on
so when I was at when I was at Yule Downs Residents Association earlier in the week in the evening, and someone asked me, they said, so do you have to make savings every year as part of what the government asks you to do? To which the answer is, yes, of course we do. And you've seen from our finance report that we had to make almost £15 million of savings this year, and it'll be an even bigger number next year. And the question is, where do you make those savings?
By building hospitals that don't exist.
So you could say that you make the savings by, let's have less clinical staff. Well, what you can see in this organisation is we're absolutely determined to have more clinical staff.
You've got shortages.
And so if you look at how many clinical staff we have now compared to 2 years ago, we've got over 300 more clinical staff now than we did. That costs more money. So when you have people like Marks and Spencers and Smiths saying,
Taking that hospital route,
saying,
you're selling the rest.
saying
Brilliant.
we'd like to come onto your site and pay you rent, what you're actually doing is helping save money without impacting on frontline clinical care.
Money. You're not talking about patients.
It's not applications,
Well,
because
actually,
you have a
there's
shortage
another
of clinical staff.
category,
You've
you
said
know,
that.
and I don't care what the rules are. The people at Epsom don't understand anything about what's going on, right? And that's okay, you can blame me, but I'm 80 and I'm not prepared to put the effort in, right? But the people of Epsom need to know what's going on. And we do not, I'll speak for them, and I don't have a voice, right? But taking away land from a site that has been here for how long, Daniel? I won't say what it is, you can tell me what it is, because we always disagree, right? It's well over 100 years, healthcare on this site, right? And the land is here to be used for the hospital, and for the public around it, right? And we're wanting, I was going to ask a question about nurses, I'll say it now, right? And I was going to ask about television and whether the television programmes at each hospitals contribute or the reverse to the recruitment process, and can we make use of the television programmes to do that? But that aside, we could have nurse training on this side if we didn't have degrees, or we had degrees in a different way, yeah? But that land is there for the public, not for you and your career, for the public who live here. And I've said enough.
Chairman. So perhaps Charlotte should just talk about how many nurses we are currently training, because it's huge.
We've heard that, Daniel.
You've already had that before.
So we have nurses in... No, we haven't actually, Dave. We have nurses in training from two universities, St George's and Kingston, and we also aspire to set up our own training school, actually, because we're training 2-year trained nurses through the Associate Practitioners programme. So we have every intention to bring nurse training back on site. We have to affiliate them to a university because nurses deserve to be educated to degree level like everybody else, and actually it does make better outcomes for patients.
Does it?
Yes, it does.
I think...
On the accommodation bit, Bob, right? So one of the buildings at the back that we'll have the conversation about declaring surplus is the building where there is accommodation in it. The accommodation is absolutely awful, and you really wouldn't want to live in it. We have tiny single rooms where about 30 people are sharing bathrooms. And the cost of sorting that out is just astronomical. And what we're actually doing is forming partnerships with other organisations around Epsom, like the universities and the colleges, and we are creating much nicer places for people to live, where it's more like living in a new piece of student university accommodation, which has a small number of bedrooms that share decent sitting rooms and washing facilities. And it is much more attractive for us to recruit people when we're saying this is the offer, than come and have a hutch in a building where everything is falling apart. So it's not. We are not doing anything that prejudices any of our sites, providing all of the healthcare that you could conceivably need for the future.
Selling the rest.
And not
I'm
maintaining
going to
it.
move us on. So there, and then Bess, and then we're going to have to finish.
Thank you. Right. Daniel, my name is Gerald Tasker, Sutton and Tune Labour Party. I would like to know, please, a number of things. First of all, why haven't you, during your consultant meetings, mentioned anything about Sevils, or changed the designation of the land that St Helier, for instance, is on from health only to residential? Why haven't you mentioned that during your secretive plans with Sevils? Why haven't you mentioned that to the people that you have consulted with? Okay.
No, he hasn't.
That's the first thing. The engagement. That's the first thing. Okay. The very fact that you haven't mentioned these things really makes the consultation process null and void, which means you've now spent thousands of pounds doing this, and you're now open to judicial review, and you've just wasted a load of money doing this. Do you not think it's time for you to reconsider your position as a result of your lack of faith in the people, lack of information to the people, and not preparing to be upfront and honest with them from the very outset? Perhaps you should move on, and perhaps this board should reconsider their position, because the people of Sutton and Tune, Epsom, do not want any of these downgradings of their hospitals. That is quite clear from the numerous petitions that have been handed into you by Kosh, okay? And it's time for you to reconsider. The Labour Party, especially when we get councillors in Sutton and Tune, will not stand by and allow this to happen, and we will fight it every step of the way. With judicial review, and on council, we will block any attempts to downgrade St Helier Hospital, close St Helier Hospital, or set up any part of it. So I'd ask you to reconsider your position. Thank you. And I'd like to know your answer.
Hold tight, this meeting is in Epsom, not in...
But it applies to both. It applies to both St Helier and the Epsom Hospital. We will protect both hospitals, and we will not allow this to happen.
let me just say on behalf of the board, Daniel has been our chief exec for more than 3 years, coming into his 4th year, which is a very long time for an NHS chief exec. He has helped this trust to meet or beat the A&E standards so that we're one of the best in London. We've hit our financial control totals, and we've done a whole load of capital investment both on this site and at St Helier over the last 2-3 years, and we will continue. So there's no wish whatsoever on behalf of this board for Daniel to consider his position. In fact, we think that he's doing an excellent job.
I'm glad for you, but we think he's not doing a brilliant job. We want to ask the question, let Daniel answer them.
So let's just be clear. I'm really proud of the things that Epsom St Helier has done under the leadership of everyone around this table. I applied for this job 3 times in my career because I've been a local resident for decades, 2 decades, and I want Epsom and St Helier to be brilliant hospitals. That's why I applied for the job, and I think we've done a huge amount to improve the quality of care that we can offer. On the subject of being open and transparent, I don't think we could have been more open and transparent with the public last year.
Why did you fail to tell people about your dealings with Savills during these processes?
Because the thing we were engaging on was being open and upfront with the public to say that we have a clinical viability issue, we have a financial viability issue, and we have an estates issue. So the big thing we were talking to the public about wasn't about spending a few £1,000s with a land agent to help us manage our estates issues. It was, how do we secure £400 to £500 million to get a new critical care hospital?
£20,000 you spent with Savills, okay? In order for them to go to the council to try and change the designation of the land. Why wasn't that important at the consultation meetings?
So you've already heard that we didn't spend £20,000 with Savills to write one letter to the council. You've already heard from our estates director that we have employed Savills for a long time to be helping us with.
Why didn't you tell people
because
in the consultation meetings about your secret dealings to try and get the land changed from health to residential?
Okay, so I'm going to say two more things, and then we're going to end this conversation, because the thing that we were engaging the public on was, can you see our clinical case for change, which says, if we want to carry on providing hospital-based services for the 500,000 people that we currently do, we can't carry on as we are, and in order to provide brilliant healthcare for the future, we need a new hospital facility that's going to cost hundreds of millions of pounds.
Daniel, and that's exactly what you said. You never told them you were taking away 2 others.
So that is what we engaged on. Now, will you manage, if you come into power in Sutton, to take our judicial review over what we do? The answer is no, you won't. And you won't because we did an exemplary piece of engagement where the body that judges whether the engagement was good, the Consultation Institute, formally wrote to tell us this was a really good piece of work that we had done. So you can instruct some lawyers to see whether you can get a judicial review, and I can guarantee you will not get a judicial review on the process to date.
We will fight this to the very end, and you will be held to account.
Right, we've only got a few minutes left, so I'm going to go to Bess. And then Bess.
Thank you for your replies.
All the accommodation here, Rowan House and over there, they're all filled with people. Where are they going to go? Are you going to rent another expensive building in Epsom like you've got already? It's a waste of money. Why not use the buildings you've got?
Existing.
Rowan House could be converted into nurses' units. It would entice more people into the area. It would be on the site and it would be there rather than go to private housing. Why waste all that money?
It's disintegrating, not integrating.
It's a bit of the land.
So Beth, I think, first of all, we need to look at it. Rowan House is not fit for purpose. It has a massive backlog maintenance and a massive build to get it fit for purpose. We have around 30% of our residential accommodation vacant, and nurses are very clear that they don't want to live in that sort of facility. They want to have families, and they, as they go through their career, and actually they don't want to live on the job. And so it's really much changed on that. The amount of investment to change Rowan House to more improved accommodation is not best use of the Trust's limited capital resource that we've got, where we want to be focusing it on the benefit to the patient and not necessarily a few nursing staff. Obviously, it's important that we provide them with accommodation, and that's why we're working locally with the universities, etc., about providing more appropriate accommodation for those nurses. The other challenge is that we're using Rowan House, a building that's designed for old nursing accommodation. For admin, it's totally inappropriate. We struggle with getting medical records in and out and providing an appropriate environment for those staff. So we'll be looking at a number of companies. We also know that therapies are on the ground floor. So we're looking at all of the therapies provision being relocated to Langley Wing, closer to where a lot of the actual care is taking place, certainly on the stroke unit, and combining some of those resources. We're looking at people like social services and the discharge, linking more closely and being next to the Epsom Health and Care team. So we're actually around the patient and the centred care around that. And we're also looking at some facilities of corporate services or facilities that are not providing direct patient care going into office accommodation that is designed and fit for purpose for offices.
Another thing is they're going to build 300 houses. The government have said there's got to be 300 houses built in the Epsom area and the Mole Valley. Are you thinking of the future when the hospital will need to expand? Where will they go? They're always saying now that there's not enough GPs, and it's terrible. You don't think of it, you just think of the moment and what money you can get.
So I think we've been very clear about what potential needs are for the future of Epsom St Helier, and certainly the Epsom site as well. We are proposing buildings that are not fit in any shape or form to provide future healthcare services, and we have also ensured that we've got facility or space on the site that we can build future facilities.
So we are for serving 40% up to 40% fewer people than you currently serve. How is that sensible? We've got a 24% increase in population in prospect. How is that ever sensible?
So we are looking at the front of the hospital in terms of the Helier wing, which is an old building, and providing a new facility there as needed, and where we believe that we can increase our existing clinical, more appropriate facilities for patients.
Thank you.
Can I presume a right to say...
You're the last one because we're out of time.
As over 50 years ago, I worked as a nurse in Epsom District Hospital, and that is my interest. Also, I paid tax all my life, and the land that belongs to the National Health Service belongs to everybody who paid tax. So I think it's unethical. This Naylor report, whatever rights it gives you, is totally unethical. I mean, I now live in another area. I'm interested in Epsom because I worked here. I lived and I worked here. And I'm really disappointed that now the committees that are set up in the hospitals have such a different attitude to the health service. You know, it's actually, as we know, being privatised, and this is all part of it. You won't have that land in the future to do for the people who are coming along. You know, the population's growing. So it really distresses me, and I think it's totally unethical.
Thank you all for coming. We will see you the next time. Dave, we've run out of time.
You are not reporting questions from the public. The last time I was at a meeting here, I wanted to exercise my legal right to film the meeting. You threatened to get security to eject me from the premises. You made a recording of that meeting in which the questions from the public are inaudible when you put it online. Also, questions from the public are not fully reflected in your minutes of meetings. Why are you not telling the truth in your reports? I made a point of repeating my request and my insistence on my right to film at the end of that meeting where you threatened to throw me out. and it's not being recorded in the minutes, nor was it audible in the recording that was put online.
So let me just be clear. We absolutely did not say we were going to get security.
Yes, you absolutely did.
No, we did not. And
Is someone lying then? Who's lying? Are you lying or are they lying? Who's lying? They're saying that you did.
And in the way we run the meeting, the questions are not part of the public meeting. You'll see on the agenda, the meeting closes, and then we have a conversation with the public. That is why they're not in the minutes.
Questions from the public, and it excludes the ones that you don't want to have asked.
There's an error on page
Total
10.
dishonesty. This whole system is totally corrupt.
Yeah.
10,000 extra people died in the first few weeks of this year because of the process of which you are a part. There's clinicians around this table who, I don't know how they square their consciences with what's going on. You haven't got enough capacity at St Helier. This is demonstrated by your need to escalate the fact that all children's services were stopped so that you could move A&E patients into those premises. People whose procedures under elective care have been deferred will have worse outcomes because of that. You are involved in the deliberate destruction of the NHS. You know it, we know it.
Now put that on your minutes.
Can I have that recorded, please?
Put it on your minutes.
Why are you not reporting all the questions that the public ask? I want an answer to that in the minutes.
Please.
Thank you all for coming, and we will see you next time.
You most certainly will. Thank you very much.